Okay. Well, thank you very much. My talk today is on atrial fibrillation, pathophysiology, mechanisms, and new treatments. And I've tried to emphasize the translational elements. So here's an outline of the presentation. I'm going to talk about the mechanisms of AF initiation and ectopic beat formation, the mechanisms of AF perpetuation and progression and electrical correlates, AF-related remodeling, heart disease, and risk factors, and finally, inflammation as a mechanism and a therapeutic target. So this is a very broad general schema of AF mechanisms. So the two principal mechanisms involved in AF in general terms are reentry and ectopic activity. Ectopic activity is well known to act as a trigger on a vulnerable substrate for the initiation of AF. The substrate requires properties that allow for the initiation of reentry, which then requires specific properties to maintain itself. Once reentry is initiated, factors are brought in that produce its perpetuation, and then when re-entry persists for a long period of time, the AF substrate progresses so that there are more complex forms of re-entry that are much harder to stop and prevent from recurring. This is the now classical observation from Michel Eysaguer and Pierre Jaïs of the common occurrence of sources in the pulmonary vein that initiate and in many cases often maintain AF. This initiation can also progress to a perpetuation by the maintenance of atrial fibrillation via a sustained automatic ectopic focus. On the other hand, the more classical involvement of foci in AF is as an initiating trigger acting on the vulnerable substrate to produce reentry with perpetuation and progression. So what do we know about the mechanisms of spontaneous ectopic activity in atrial cells from long-standing persistent AF patients? This work was first authored by Niels Vogt in studies performed with Jordi Hyman and Dobromir Dobrev in Dobry's lab in Essence. So this is a recording during sinus rhythm of intracellular calcium activity at the top and transmembrane potential at the bottom. Each of these activations was produced by field stimulation of this cell. And you can see that the cell depolarizes and repolarizes repetitively in response to stimulation, and that intracellular calcium content, or at least activity, goes up with activation and then returns to the diastolic level following repolarization. And at the cessation of stimulation, you see that the cell is relatively quiescent with no spontaneous calcium releases and no changes in the transmembrane potential. This is a recording from a patient in atrial fibrillation. And you can see that unlike the recording from the sinus rhythm patient, which was quiescent after the end of stimulation, now you see a series of spontaneous calcium releases associated with spontaneous activity. So the question then is, what could be the underlying mechanisms? What is making patients with atrial fibrillation prone to spontaneous calcium releases and ectopic activity? So in this schema, I review the factors involved in generating the principal mechanism that we believe to be involved in spontaneous activity, which is delayed after depolarizations. So delayed after depolarizations occur when there's a spontaneous diastolic release of calcium through the ryanodine receptor. So to review the physiology of this structure, this yellow business represents the cell. with the cell bilayer cell wall at the top, the sarcolemma, the cytosol below that, and within the cytosol, there are a number of intracellular organelles, including things like mitochondria, endoplasmic reticulum, Golgi apparatus, and sarcoplasmic reticulum in cardiac tissue. The sarcoplasmic reticulum is a series, it's actually a network of storage vesicles connected to each other to create a continuous network that stores calcium. And the job of the sarcoplasmic reticulum, or SR, is to take up calcium so that the intracellular concentration is low, allowing the cardiomyocyte to be relaxed in diastole, and then release that calcium very quickly in response to an intracellular calcium entry through the L-type calcium channel, and then take it back up again quickly through the sarcoplasmic reticulum calcium ATPase, or SERCA. Normally, there's no release of calcium in diastole. The cell is relaxed and everybody's happy. But under certain conditions, there can be a spontaneous diastolic release of calcium, and that has to be handled somehow. Otherwise, the cell will get calcium overloaded and fail to relax, causing diastolic dysfunction or even severe heart failure or death. So this calcium is handled essentially in two ways, partially being taken up by SERCA, but also partially being transported out of the cell through the sodium-calcium exchanger. The sodium-calcium exchanger is an energy-requiring active exchange using ATP to generate energy for ion movement. It, in this case, extrudes calcium in exchange for extracellular sodium. For every one calcium ion that's removed by the exchanger, 3 sodium ions are transported into the cell. And as you will understand, 3 sodium ions have a net charge of +3. The calcium ions have a charge of +2, and the difference is one positive charge, is a difference of one extra positive charge in the inward direction, meaning that this transporter is electrogenic, so that with each cycle of the sodium-calcium exchanger, there's an inward movement of one extra positive ion that tends to depolarize the cell. And when this movement is fast enough, it generates a measurable current, a measurable inward current due to the inward movement of sodium ions, which causes a measurable depolarization, which is referred to as a DAD. When the DAD is relatively small, it doesn't reach threshold, it doesn't cause spontaneous activity, but when the DAD is larger, it reaches threshold for activation and causes a spontaneous action potential. So I just went through this system. I will now go through the results in patients with chronic AF. So these patients had AF for at least 6 months on a continuous basis, and Niels measured the amplitude of the spontaneous calcium release by this protocol. The transmembrane potential is clamped and transmembrane voltage is measured. L-type, the calcium, all of the currents other than the sodium-calcium exchanger are blocked using different potential blockers. And then the transmembrane calcium, the intracellular calcium content is measured with calcium-sensitive dyes, and tetracaine is applied. Now, tetracaine blocks the sodium-calcium exchanger, so it causes an inward movement of calcium, which can be measured, it blocks the exchanger, which causes a movement of calcium, which can be measured. And it's this movement of calcium that indicates the size of the sodium-calcium exchanger. So in patients with longstanding AF, KN92, the calcium calmodulin 2, type 2, CAM kinase 2, calcium calmodulin dependent kinase type 2 blocker, KN93, eliminated the difference in the spontaneous calcium release between the AF cells, shown in black, and the control cells. So under control conditions with no blockers, you see that the SR calcium leak is enhanced in patients with AF. This is not affected by the pKa blocker H89, is blocked by KN93. You see the difference in spontaneous calcium release is eliminated, and unaffected by an inactive congener of KN93, KN92, which is a standard control. So this increased calcium leak points to ryanodine receptor dysfunction as the mechanism underlying the DADs in these patients. The next step in this work was to identify the potential mechanisms, and Niels measured the phosphorylation of the ryanodine receptor at two different sites, the primarily CAM kinase dependent site, serine 2808, and the mixed CAM kinase pKa site at 2814. And you see both of the sites were hyperphosphorylated on these Western blots. So this indicates that the ryanodine receptor is hyperphosphorylated, likely via CAM kinase, because both the CAM kinase site and the pKa/CAM kinase site were hyperphosphorylated. And hyperphosphorylation of the ryanodine receptor makes it hypersensitive to calcium and will cause spontaneous calcium release. So this result indicates that CAM kinase 2 mediated ryanodine receptor hyperphosphorylation is involved in chronic AF. So ryanodine receptor dysfunction due to CAM kinase mediated hyperphosphorylation, which causes leakiness of the ryanodine receptor, appears central to the pathophysiology in these cases. Okay, so next, Niels examined sodium calcium exchange function, because even though he found that the ryanodine receptor was hyperphosphorylated, that doesn't exclude the participation of other mechanisms like increased sodium calcium exchange activity, which will, for any given calcium released by the ryanodine receptor, enhance the current and produce a larger DAD. So Niels found that the sodium calcium exchange current was increased, whether measured directly or as a function of calcium concentration. He also noted that the transcriptome expression of this NCX1, which is sodium calcium exchanger mRNA, was enhanced, as was NCX1 protein on Western blot. So NCX is upregulated in chronic AF and could contribute to DADs along with ryanodine receptor hyperphosphorylation and leak. The weakness of these data is that chronic AF, longstanding persistent AF, is most likely maintained by complex reentry. And while an increased tendency to ectopic activity could participate, particularly if there's a termination of the AF, it's not the primary mechanism maintaining AF in longstanding persistent patients. So then Niels and Dubry asked, what happens in persistent AF where focal activity likely plays a bigger role? And these are recordings that were done a couple of years after the ones I showed you before, looking specifically at cardiomyocytes from atria of control patients versus patients with a history of paroxysmal AF, defined as AF with no single episode lasting more than 7 days. So first of all, the incidence of spontaneous calcium releases was much higher in patients with persistent AF than in the control patients. And you can see the differences in spontaneous calcium release at the top and membrane currents. These are spontaneous currents in response to these calcium releases at the bottom between paroxysmal AF patients and control patients. Niels then went on to look at the underlying molecular mechanism, and without going into the original data, he found that in contrast to the chronic AF patients that I showed you that had increased sodium and calcium exchanger expression and function and ryanodine receptor dysfunction due to CAM kinase hyperphosphorylation, in patients with paroxysmal AF, there was an increase in intra-SR calcium, which was not the case in the controls, due to an increase in SERCA activity, an activity of the sodium sarcoplasmic reticulum calcium ATPase. So the key points to take away from these observations is that atrial ectopic activity is involved in initiating and possibly maintaining AF, that atria from AF patients show a tendency to generate ectopic beats through calcium-mediated DADs, and both chronic AF and persistent AF patients manifest DADs due to abnormal calcium, but the mechanisms are different in the two conditions. So in summary, ectopic activity, particularly from the pulmonary veins, plays an important role in AF, and a major mechanism of ectopic activity generation appears to be related to DADs caused by spontaneous calcium releases due to abnormalities in cellular calcium handling. The next set of information I'd like to discuss with you regards mechanisms of AF perpetuation of progression, clinical correlates in relationship to AF-related modeling, heart disease, and risk factors. So I showed you at the very beginning this schematic of AF pathophysiology, and we discussed now the mechanisms underlying initiation of ectopic activity. What about perpetuation and progression? So AF perpetuation is a very interesting phenomenon that's related to this mechanism originally reported by Moritz Alessi in 1995. This experiment was performed with normal goats in a model that's still used in Maastricht. The goats are instrumented with electrodes in their right atrium that are connected to a computer circuit that can induce AF, puts out a burst of pacing to induce AF, follows the rhythm until sinus rhythm is restored, and then induces AF again. So with this program, Dr. Alessi's lab was able to get an ongoing log of the duration of AF episodes before spontaneous termination, as well as maintaining the goats in AF for the entire experimental period. So you can see that under baseline conditions, spontaneous AF rapidly self-terminated, just as would probably happen if I took any of you to the EP lab and induced AF in your atria. The AF would spontaneously terminate quite rapidly. However, after 24 hours of artificially maintaining AF, these goats had much longer sustained AF before it self-terminated. And after 2 weeks, 85% of the goats were in indefinitely maintained AF without any electrical stimulation. So this experiment was critical in demonstrating that AF itself alters the properties of a healthy atrium in ways that promote AF occurrence. And of course, if the atria are not healthy, then this phenomenon is enhanced, as we demonstrated later on. So if we look at this diagram, this is taken from a paper that I wrote in European Heart Journal in 2014, advocating early intervention for AF. So this is a schematic diagram of the natural history of AF. Now, of course, it's just a conceptual diagram, but it does have significant applicability. So early on in the natural history of AF, the episodes are often very short. However, in some patients, many, the AF will become longer lasting and will need to be converted by cardioversion. And this may happen several times in the natural history of the disease. With each AF episode, remodeling occurs, and we'll discuss the mechanisms in a moment, that occurs rapidly and then resolves fairly rapidly. However, in many cases, the remodeling in response to AF doesn't resolve completely and leaves a residual. And with repeated prolonged AF episodes, there's an accumulation of this degree of remodeling such that it's now irreversible and can lead to permanent AF. So if we look at the factors promoting AF maintenance as a function of the lifetime, on the vertical axis is the AF substrate quantified in a conceptual fashion, they're not real numbers, as a function of age on the horizontal axis. So a higher position on the vertical axis would indicate a larger AF substrate and a greater likelihood of maintaining AF. And the horizontal axis represents age here from 40 to 80. So one factor involved in AF promotion is simply normal aging. And we've been studying some of the mechanisms. They're quite interesting. The work is ongoing. A second factor is cardiovascular disease-induced remodeling. So anyone with significant cardiovascular disease will have changes in their atrial properties that make the atria more prone to occurrence and maintenance of fibrillation. And finally, there's AF-induced remodeling, which, as I mentioned, accumulates with each episode, starts resolving when the episode is terminated, doesn't necessarily completely resolve depending on the duration of the episode, and can accumulate, contributing to the overall substrate. So if we look at the AF-induced remodeling substrate, which is responsible for perpetuation of AF, a very important component of it is the electrical changes in response to tachycardia. So during AF, the atria are being driven at 400 to 600 per minute. With each atrial firing, calcium enters the cell and tends to increase intracellular calcium. The cell has to protect itself against this enhancement of intracellular calcium and does so in several ways. First, there's ionic current remodeling, which results in a decrease in L-type calcium current and an increase in inward rectifier IK1 current. These phenomena shorten the action potential, which in itself will reduce calcium load. And of course, a decrease in L-type calcium current will directly reduce calcium load by reducing the amount of calcium coming into the cell during phase 2 of the action potential. So that reduction in calcium, both from shortening of APD, action potential duration, and reduction of calcium entry, tends to feed back negatively on calcium loading and protect the cell. On the other hand, it shortens action potential duration, which is one of the main determinants of reentry and promotes persistence of the tachycardia. In addition, cellular calcium handling is remodeled, resulting in a tendency to form DADs and spontaneous activity, which will promote the reinitiation of AF if AF stops. So Action potential remodeling involves both a decrease in L-type calcium current and an increase in background potassium current to shorten APD and ERP, this part of the equation. And in addition, changes in calcium handling cause ectopic beat initiating DADs. What about longer-term remodeling? So what I've shown you here is involved in the perpetuation of AF and the phenomenon that Moritz Alessi demonstrated with his AF induction model. But we saw that with longer-term AF, you get irreversible remodeling that is not due to these electrical changes, which reverse promptly when AF terminates. So these are isochrone maps at the top and wave maps at the bottom from Moritz Alessi's goats. And actually, no, this is from a patient. I'll show you the goat data in a moment. This is from a patient in sinus rhythm who is acutely induced into AF. So this, the way in which this is recorded is by taking a high-density multi-electrode array and applying it in the operating room to the left atrium of a patient. And you can see that the isochrones, which indicate the activation intervals in this patient, in this region of the left atrium, in this patient, sinus rhythm patient, are relatively well organized. So just to review what this is during AF, during induced AF. You see that during this cycle of activation, the region is activated by a broad wavefront. This portion of the tissue is activated in the first 10 milliseconds of the window, this in the second 10 milliseconds. This should be reading 30. I think this is 30 milliseconds, 40, 10. So the activation is obviously not completely symmetrical because it's during AF, but you do see that the wavefronts are quite broad. And this is another cycle in that individual, which is more disorganized, but nevertheless, the wavefronts are fairly broad and organized. At the bottom are vector maps that Dr. Alessi developed, vector wave maps to look at the progression of specific waves. And in this cycle, in this patient, you see these broad wave fronts. In the next cycle, you see somewhat more numerous and smaller wave fronts, but they're still pretty organized. At the right are comparable data from a patient in AF, and you can, in long-standing persistent AF. And you can see that these wave fronts are much more disorganized, involve many more wave fronts, smaller isochrones indicating very slow conduction, and the wave maps at the bottom of these two cycles, so these are two individual successive cycles, show a great deal of longitudinal dissociation and disorganization of these waves. So the increased complexity of activation with many more reentry zones suggests longitudinal dissociation of conduction pathways. I'm not going to go through this in detail, but these are comparable data. These are actually isochrone maps in goats with either short-term or long-standing persistent AF. And you can see qualitatively similar properties. That is, with short-term AF, the wavefronts are larger and well-organized. These isochrones are larger. Whereas in the patient, in the goat, with long-standing persistent AF, you can see these very narrow isochrones, very complex activity, and many wavefronts. So the increased complexity of activation in these goats with many more reentry zones in the presence of AF is similar to what we saw in the human data. So what is the underlying mechanism? When you compare in these goats their atrial structure, you can see that the goats with short-term AF had relatively little collagen, relatively little connective tissue interrupting muscle bundles. Whereas in goats with long-standing persistent AF, you can see a very complex honeycomb-like connective tissue structure, almost like a connective tissue skeleton to the atrium, which is much more complex and much more which isolates the cardiomyocytes into much smaller and complex bundles. So as AF becomes long-standing, fibrosis develops, particularly in the endocardium, and separates myocytes, creating conduction barriers that can stabilize multiple reentry zones. So the key points to retain from this are that long-standing AF itself may be able to cause atrial fibrosis, and that it may be therefore important to control AF as early and as effectively as possible to improve the effectiveness of therapy. We looked at the occurrence of and properties of AF-induced atrial remodeling in dogs with a controlled ventricular response. So the question we were asking is this pathophysiology dependent on some degree of cardiomyopathy and heart failure, or can you get fibrosis in response to just AF itself, as our much earlier experiments had suggested in isolated cell models? So we took different groups of dogs. This is what there was a control group, a group with AF with AV block, where AV block was performed to allow for a lack of atrial control over the ventricular response, and all dogs were paced at 80 beats per minute to control the ventricular rate. AF without AV block, so here there was no rate control, and the mean ventricular rate was around 160 beats per minute, which would produce some degree of myocardial dysfunction. Ventricular tachypacing at 160 beats per minute. So here the atria are not fibrillating, but we're looking purely at the effect of ventricular rate on atrial properties. So with a fast ventricular rate, you may expect to see some decrease in ventricular function and response, the response of atrial remodeling. And in some dogs, to look at the effect of severe heart failure on atrial properties, we ventricular paced at 240 beats per minute without AF. So these are data on AF vulnerability, so the ability to induce AF. And you see here that in AF with a controlled ventricular response, so only AF, you nevertheless have a lot of vulnerability. AF without AV block, you get an increase in vulnerability that's a little bit more than with AV block. Ventricular tachypacing alone, so now we're mimicking the ventricular rate that occurs in dogs with AF without AV block. You do see an increase in atrial vulnerability. Atrial vulnerability is defined as the ability to induce AF by single premature beats, but it's relatively less than in AF with or without AV block. So these experiments at the left indicate that the main factor making the atrium more vulnerable in the presence of AF is the AF itself, and that while the rapid ventricular response may increase atrial vulnerability to some extent, it's much less than the AF effect per se. Left atrial refractory period was reduced in the presence of AF with or without AV block, but not affected with ventricular tachypacing. And AF duration was most increased in the group that combined the atrial rapid rate and the relatively rapid ventricular response, not particularly prolonged with only the rapid ventricular rate. So that didn't seem to be a key factor, and prolonged to some extent, but not as much by AF with AV block. If we look at the effects on conduction, atrial conduction was prominently affected, as these are the mean data at the right, by in all three groups, but particularly in the group that combined both rapid ventricular response and atrial fibrillation. And atrial action potential duration was reduced only in the groups with AF. If we then look at tissue fibrosis, which now is the mechanism underlying progression of AF, we see that both factors are involved in tissue fibrosis. When you reproduce the rapid ventricular rate due to AF, there's some degree of enhancement of atrial fibrosis, presumably due to ventricular dysfunction and the neurohormonal response. But if you have AF, even with a perfectly controlled ventricular rate, you still get an increased amount of fibrous tissue. And when you combine the two, you get an enhancement in the amount of fibrosis that occurs. And of course, the largest amount of fibrosis is when you have an overt heart failure syndrome induced by ventricular rate of 240 per minute, which is a ventricular tachycardiomyopathy. If we then look at changes in left ventricular function, there were no significant changes in AF with AV block. They weren't statistically significant, but nevertheless, there was some decrease, which we've shown to be significant when looked at by itself. With AV, without AV block, you have a substantial reduction in LVEF, as you do if you just mimic the rapid rate. And then with congestive heart failure, with very rapid ventricular activation, you see the largest decrease in LVEF. So the bottom line of this work is that even with a controlled ventricular rate and unaffected ventricular function, AF causes AF promoting conduction abnormalities related to tissue fibrosis. So what are the clinical implications of AF associated fibrosis? So this is from these data are from studies done from the group of Nasir Marouche in Utah. He developed a technique to measure an index of atrial fibrosis in vivo via late gadolinium enhancement MRI. And you can see that when atrial fibrosis was less, as indicated by late gadolinium enhancement less than or equal to 35%, AF was much less likely to recur than when there was extensive atrial fibrosis. So advanced fibrosis predicts a low likelihood of sinus rhythm maintenance. What about cardiovascular disease-induced remodeling substrate? So the first question that we asked is, to what extent does ventricular rapid rate causing heart failure produce atrial fibrosis? So we took dogs and tachypaced them at 240 beats per minute for 3 weeks, and then at a slightly slower rate for 2 weeks in order to produce substantial congestive heart failure. And we found that these dogs developed AF. We also compared the AF due to heart failure with AF due to just a rapid atrial rate. We see that AF duration is increased in both, but that a rapid atrial rate, as I showed you before, reduces atrial refractory period, whereas ventricular tachypacing does not. And the wavelength for reentry, which is an index for a classical index for reentry, is reduced markedly by rapid atrial rate, but not by rapid ventricular rate. And the underlying substrate for the AF in the heart failure model is shown on this slide. These are Masson trichrome stains, which indicate cardiomyocytes in pink and connective tissue in blue. You see that in control, you have just very fine connective tissues. Septi, this is the same with rapid atrial rate, but a controlled ventricular rate. But with a very rapid ventricular rate and significant heart failure, you see this very extensive atrial fibrosis corresponding to regions of conduction slowing. So fibrosis underlies the AF substrate in congestive heart failure, that's atrial fibrosis, and many other cardiac pathologies. And this is an important paradigm because clinically in most AF patients, we don't see a significant reduction in ERP and wavelength, but we do see evidence for fibrosis. So thinking about how you're going to manage AF better and handle the occurrence of this atrial fibrosis in response to heart disease, as I showed you, or even in response to AF alone, as I showed you in the work before, it's important to know if this fibrosis is reversible. If it's reversible, then you can attack it in the patient with long-standing AF. But if it's not reversible, it's very important to prevent it before it happens. So the protocol we used was ventricular tachypacing to induce heart failure, and you see the LV ejection fraction went down quite substantially, followed by a no pacing recovery period in which the ventricular ejection fraction went back completely to normal. If we look at the left atrial area in these dogs, during ventricular tachypacing, the left atrium, and these are measurements in ventricular diastole shown by the open circles, or ventricular systole shown by the closed circles, and you can see that atrial dimensions increased during the 2 weeks of ventricular tachypacing and then recovered completely during the no pacing recovery period. However, if you look at fibrosis, these are, again, Masson trichrome stains from dogs, from control dogs, from dogs in which congestive heart failure was induced without a recovery period. So they got 2 weeks of tachypacing and were sacrificed were euthanized at that point, or with a 4-week recovery period during which we saw complete hemodynamic recovery. So the question is, does this fibrosis that you see after 2 weeks recover during 4 weeks of recovery when there's full hemodynamic recovery? And as you can see, so these results are fibrosis in the control dogs and in the dogs with heart failure induced by 2 weeks of tachypacing versus dogs with 2 weeks of ventricular tachypacing followed by full hemodynamic recovery, and there's no change at all in the degree of fibrosis in the dogs allowed to recover hemodynamically. So these data indicate that the heart failure-induced structural substrate does not recover, which makes it very important to consider that in managing patients in terms of recovery possibilities. If you look then at electrical properties, we see this is the ERP, or effective refractory period, which was markedly prolonged in the atrium with heart failure and recovered fully at the end of the recovery period. Nevertheless, the duration of AF was unaffected. So these data suggest that advanced fibrosis, as seen with significant ventricular heart failure, advanced atrial fibrosis, as seen with significant heart failure, does not seem to be reversible and maintains a substrate for long-lasting AF. So does this have implications for AF management? It would seem to suggest that it's important to intervene early in patients with substrates that can lead to AF, which include, so with disease that can lead to AF, which includes things like heart failure, valvular heart disease, or even AF itself, to prevent the development of irreversible remodeling. And I want to present now the results of the East AF study, which was a very interesting multi-center study, and which selected patients at risk for cardiovascular events, recruited in a whole variety of primary locations like cardiology offices, medicine offices, emergency departments, etc. And they took patients with recent onset AF and patients without known AF, but positive for AF on ECG screening, and then randomized them to 2 approaches. early rhythm control, which, as you'll see, was primarily with antiarrhythmic drugs, although pulmonary vein isolation was used in some patients. And then in patients, in case of AF recurrence, either the patients were subjected to repeat ablation, to adaptation of antiarrhythmic drug therapy, or to crossover to ablation. And then there was a usual care group that got rate control supplemented by rhythm control only in symptomatic patients, despite optimal rate control therapy, as mandated by the 2010 ESC guidelines for AF. And then the patients were followed up and got antithrombotic therapy. So we can see that the cumulative incidence of the primary endpoint, which included AF, death, and hospitalization, was greater in the usual care group than the early rhythm control group. And the different components of the first outcome were cardiovascular death, stroke, hospitalization for worsening heart failure, and hospitalization with acute coronary syndrome. Of these, early AF management, management applied as early as possible, significantly reduced cardiovascular death and significantly reduced the incidence of stroke, and also reduced, but not statistically significantly, the number of hospitalizations. Interestingly, the nights for hospitalizations, I should say, for heart failure and acute coronary syndrome, the total number of nights spent in hospital were slightly greater for the early rhythm control group, mostly because of hospitalizations for recurrences of AF. If you look then at the therapies of these patients, these are the different antiarrhythmic drugs that were used. So propafenone, light green or turquoise, flecainide, dark green, amiodarone, pink, dronedarone, orange. You see that the whole range of antiarrhythmic drugs was used, and that AF ablation was used in a relatively small proportion initially, and still only in 20% on a long-term basis. If you look at the usual care group, a relatively small proportion of them were subjected to rhythm control therapies. So this study showed that early and aggressive rhythm control improves outcomes in AF patients, likely at least in part by preventing irreversible atrial remodeling. Let's see, what time is it? All right. Maybe I'll just finish with the second important corollary of the phenomenon of remodeling due to heart disease, and that is the occurrence of remodeling with well-known cardiovascular and AF risk factors. So obesity is well known to be a risk factor for AF. The group of Prash-Sanders looked at the occurrence of AF in sheep that were either overfed to become obese or fed normally. And you can see that as animal weight increased, the number of AF episodes increased in these sheep. The sheep that were overweight showed a progressive slowing in atrial conduction, both in the left and the right atrium. And this appeared to be due to an increase in the amount of fibrous tissue in the sheep, with a statistically significant increase in amount of tissue fibrosis in the very obese sheep, and both in the right and the left atrium. So obesity produces a clear mechanistic substrate for AF, related at least to fibrosis. They then followed this up with a clinical study which attacked obesity as well as other risk factors. That needs to be said. It wasn't just obesity. It was an overall lifestyle intervention attempting to get the patients to lose weight, to stop smoking, to reduce alcohol intake, and to have controlled blood pressure. And you can see that the waist circumference and weight in these patients was very high. Their average BMI was over 32. Their waist circumference was 110 centimeters and their weight 99 kilos on average. And on follow-up, they had significant weight loss in the intervention group. The control group had slight weight loss and, slight weight loss, but no real reduction in BMI. If you then look at the AF recurrence rate as detected by 7-day ambulatory monitoring, you see that the number of patients with AF episodes was greatly reduced in the intervention group, and the number of episodes and their total duration were also significantly reversed. So this is important because it shows that reversing obesity can prevent AF. We did a study in a rat model of obstructive sleep apnea in which rats were subjected to 20 sets of obstructive apnea, alternating with a period of normal breathing for a total of 40 minutes each day over a 4-week period. And we found that the rats subjected to repeated obstructive sleep apnea developed longer lasting episodes of AF and more inducibility of AF. So here you see their mean AF duration in the obstructive sleep apnea rats was greatly increased. Their AF inducibility was increased. And when you tried to induce the AF during an acute episode of obstructive apnea, so during one of these sets of obstructive sleep apneas, you saw an increase in AF inducibility, indicating that a patient with obstructive sleep apnea both develops a substrate over time and enhances the susceptibility to AF during each individual episode. So chronic obstructive sleep apnea produces an atrial AF substrate that's aggravated by acute apneic episodes. We looked at conduction velocity in these rats, and you can see that the rats with obstructive sleep apnea had a substantial and statistically significant reduction in conduction velocity that didn't occur in either the sham group, which were intubated, but the airway was not occluded, or the control group. The open airway group was the green one, and the sham was red. They didn't get the obstructive episode. So obstructive sleep apnea slows conduction. It also reduces the expression of connexin 43, which is the ion channel that sits at gap junctions and allows normal cell-to-cell communication and conduction. You can see the expression of connexin 43 was reduced in the sleep apnea rats. You can see these green things, these little green dots are the connexin protein underlying this ion channel. You can see it's very sparse in the obstructive apnea group. And there was also lateralization of these connexins, meaning they were less efficient because they weren't located anymore at cell ends. You can see this green line, which is running parallel to the orientation of the cells instead of perpendicular to it at the tight junctions. So obstructive sleep apnea not only causes fibrosis, but it reduces connexin expression and causes lateralization of expression. So what does all this mean? Well, it means we showed you already that weight loss can reverse the AF promotion due to obesity. And so these are studies from weight loss and AF progression. You can see that AF progression is reduced, and reduction in the type of AF from persistent to paroxysmal occurred in many more weight loss patients than control. And this is a study of obstructive sleep apnea. Patients, this is from Fine in Jack in 2013. They showed that patients with obstructive sleep apnea and CPAP had a rate of recurrent AF after ablation, which was similar to patients with undergoing pulmonary vein isolation, but no sleep apnea history. Whereas patients who didn't get ablations or patients who had PVI and obstructive sleep apnea, but no CPAP to prevent their obstructive episodes, had a very low AF-free survival, indicating high recurrence rate because of the persistence of this substrate forming and promoting occurrence of obstructive sleep apnea. So it's possible then to prevent development of the AF substrate, and in some cases to reverse it by suppressing AF risk factors. And the key points from this section are that heart disease and risk factors promote AF mainly by causing atrial fibrosis, and that preventing or suppressing risk factors may help to prevent AF by preventing or possibly even reversing fibrosis. So this has led to a therapeutic concept of the role of risk factor control. So we know that anticoagulation, rate control, and rhythm control are important pillars of AF management, but these recent data suggest that risk factor management, by virtue of its prevention of the progression of the AF substrate, can be an important fourth pillar of AF control. So in summary, long-term AF, heart disease, and risk factors for heart disease promote AF by causing structural remodeling. Structural remodeling reverses poorly, so early intervention to control AF, heart disease, and risk factors is important, and any therapeutic approach that doesn't involve proper risk factor control is much less likely to succeed. So now I'm going to suggest that we take a 10-minute break and reconvene at 5:15, I guess, your time. 11:15 my time, unless there are questions. If there are questions on this
already
part,
some questions around the table. Yes, Elise?
I can stop sharing here for now.
Thank you for the lecture. I have one question about the sleep apnea risk factor, because it's not completely linked in the literature. That is the hypoxemia or the hypercapnia or the acidosis which cause the AF risk factor.
Okay, so you're right that sleep apnea causes multiple factors that could contribute to AF promotion, including hypoxia, hypercapnia, acidosis. Autonomic changes can also play a role, and changes in atrial hemodynamics likely play a role. We showed earlier in another rat model of obesity and sleep apnea that acute apneic episodes cause distension of the atrium because of the increase in intrathoracic pressure, and that also plays a role. So I think that in terms of the different aspects of obstructive sleep apnea that contribute to AF promotion, it's probably not one single factor. It's probably multifactorial. However, in addition to the dimension of which of the specific risk factors is involved, you also have to consider the difference between acute AF promotion and chronic AF promotion. So the acute AF promotion resulting from one apneic period. So you can show that just inducing apnea for 30 seconds, as might occur in someone whose airway obstructs at night, in itself makes AF more likely. And that's probably multifactorial and due in large measure to the atrial distension that happens during the apneic episode, but hypoxemia, hypercapnia, autonomic changes, vagal enhancement probably all also play a role. But with recurrent apneic episodes over time, as we showed in our rat study, you get progressive fibrosis and loss of connexins, which is probably due to more complex neurohumeral and potentially other factors like localized inflammation and even cellular senescence might occur that contribute to remodeling the atrium in a more long-standing way. So it is a very complex pathophysiology, and of course you undercut it if you prevent the episodes. I think one thing that we've learned from many years of AF research is that it's probably more effective to target the initiating factors rather than trying to target individual components of the subsequent substrate. So, for example, it's probably much more effective to reduce obesity, prevent obstructive sleep apnea, reduce alcohol consumption, cause cessation of cigarette smoking than it is, for example, to try to identify an anti-fibrotic drug to try to prevent fibrosis directly or to try to make it reverse once the substrate is present.
Thank you.
If there are questions? Yes. Open your microphone.
Thank you for the lecture. My question is about the relationship between atrial fibrillation and cancer anti-therapy drug.
Sorry, between atrial fibrillation and?
Cancer anti-therapy drug.
Oh, calcium.
Cancer active therapies.
You mean things like calcium antagonist? Calcium ion
No,
channel blocker?
The drug that we use against the cancer.
Oh,
tumor.
cancer drugs? Cancer
Yes.
chemotherapeutic, okay.
Yeah.
Right. By the way, you feel free to ask your questions in French. Si c'est plus facile pour vous,
Yes,
ça
Stanley
m'est
speaks
égal.
very well French,
Je
as
peux
you can
prendre
hear.
les questions en français comme en anglais. Est-ce que vous préférez que je réponde en français?
No, a few students are not French speaking,
Okay.
so answer in
fine.
English.
So feel free to ask your questions in French and I'll give my answers all in English with a brief explanation of the question. So the question here was, what do cancer chemotherapeutic drugs do in AF? And I guess, how do you manage it? So cancer chemotherapeutic drugs cause cardiotoxicity in complex ways. And there are a number of mechanisms involved, including oxidant stress, acute induction of cellular senescence, possibly changes in cardiomyocyte regeneration, possibly fibrosis. So the mechanisms through which they promote AF are, I would say, basically twofold. One is the induction of heart failure, with AF and atrial changes secondary to the heart failure. And there you really need to target the heart failure through treatments that have been shown to be of some value, including things like manipulating the cancer chemotherapeutic protocol. If there's early evidence of heart failure, there's some evidence that statins might have some beneficial effect, and so on. The second is atrial-directed toxicity of cancer chemotherapeutic agents like ibrutinib, which is a tyrosine kinase inhibitor that has specific AF-promoting actions with complex pathophysiology related to the tyrosine kinase inhibition. That's a whole separate field in itself.
Yes, another question there. Open your.
Thank you for your presentation. I would like to know, by talking about obesity like a factor inducing AF, can we also think about microbiota or dysbiosis too?
Yeah, okay, good question. By the way, I haven't finished my presentation. I'm taking questions now, but I do have a second part, which will not be as long as
this is the last question before the pause.
But in response to your question about the microbiota, yes, they have an influence in AF. Exactly how much clinically is not clear yet, because clinical studies are still relatively young and no definitive studies have been completed. There's certainly evidence in experimental models that changes in the microbiota, the intestinal bacterial content, can play a role in AF promotion, and it appears that they work at least in part via atrial fibrosis. I'm going to talk about a recently emerging mechanism that has conceptual importance and hopefully therapeutic importance as well. So this is the first observation that put forward the concept of inflammation having a role in AF. This is from Mina Chung and David Van Wagener's group at the Cleveland Clinic, who noted that in patients with AF, the serum C-reactive protein concentration was increased. So these results are from large numbers of patients. You see 71 in the control group, 125 AF, including both lone AF and patients with structural heart disease. I don't know why the numbers don't add up, but you can see that in all of the groups of AF patients, there was an increase in the serum C-reactive protein. And you know that C-reactive protein is a non-specific inflammatory neuromolecule, which is also a biomarker for inflammation. And they compared control patients with those with paroxysmal and persistent AF and noted a graded increase in the CRP, such that the longer lasting the AF, the greater was the blood CRP level, suggesting greater degrees of inflammation. This slide summarizes the classical view of the cellular basis and role of inflammation in pathophysiology in general and in the heart in particular. So the primary source of inflammation is thought to be macrophages and other leukocytes that infiltrate disease or infected tissue and then act on cardiomyocytes, fibroblasts to produce ECM, extracellular matrix, fibrosis, and to affect vascular stability. So primary source, and the macrophages acting passively on cardiomyocyte growth and proliferation, and fibroblasts to enhance extracellular matrix production. So in this scenario, inflammatory white cells play the primary role. However, recent evidence suggests that other types, for example, cardiomyocytes, can display important intrinsic inflammatory signaling. So the concept here is that the same systems that produce cytokine release and inflammatory responses classically from macrophages and other leukocytes is also present in cardiomyocytes and may contribute to tissue pathology. Now note, the activity of these systems in cardiomyocytes is quantitatively much less than in macrophages. Clearly, because that's not their primary role, and any degree of tissue inflammation resulting from inflammatory signaling in cardiomyocytes will be at a much lower level than in macrophages or other cells. On the other hand, the cardiomyocyte signaling sources may be much more maintained and long-term. So in order to understand the data that I'm going to show you, I have to review the biochemistry or the simplified biochemistry of inflammatory signaling. So the key element to inflammation is the inflammasome. A key underlying protein is the NLRP protein, and here's what it stands for. I'll read it in a moment. And this protein aggregates with other proteins to produce this rosette-like structure, which is the inflammasome. So the NLRP3 protein is a specific subtype, which is particularly important in the heart. And NLRP3 stands for nucleotide binding domain, leucine-rich containing family, pyrin domain containing 3. And you can see why I'm going to call it NLRP3 for the rest of this presentation. rather than the full name. So NLRP3 associates with these other proteins, ASC, which you can see here is another long name. You can read it yourself. I'm not going to read it out. Procaspase 1, which is the inactive precursor of caspase 1, which is an important intracellular enzyme that breaks down other proteins, and pro-interleukin 1 beta, which is the precursor of the cytokine interleukin 1 beta, which is a very important cytokine. So in this structure, shown diagrammatically here, which is the NLRP3 inflammasome, these different proteins associate to create an organized structure that activates inflammation. The orange disc-like symbol represents NLRP3. The blue ball represents ASC, and the green oval represents procaspase 1. And they aggregate together to produce this NLRP3 inflammasome, which then acts on interleukin 1 beta and pro-interleukin 1 beta and pro-interleukin 18 to split off the inactive pro-moiety and leave interleukin 18 and interleukin 1 beta, which are active cytokines that then get transported through the cell membrane, or actually they're not actively transported. They are released from the cell through a channel called the Gasdermin D channel or Gasdermin D protein, which allows these cytokines to leave the cell and act on adjacent tissue. So there are two components to the process of activation of this NLRP3 inflammasome. The first is called priming, which involves the response to a variety of activating signals, so-called alarmings. They can be a disease-induced activating signal, or this would be, it could be from parasites, or it could be from other sorts of pathogens. And that results in an increase in the production of procaspase 1, ASC, NLRP3, and pro-interleukin 1 beta protein, often via increased increased transcript production via changes in the transcriptome through transcription factors like NF-kappa B, which then ultimately increase the quantities of these proteins. Then secondarily, there's an activating signal, so an immediate signal that causes these proteins to assemble into the active NLRP3 inflammasome and to release cytokines. So this is work that we did in collaboration with Na Li in Houston and Zander Verens and Dobromir Dobrev. They looked at the expression of NLRP3 components in patients with paroxysmal AF or persistent AF, or in our canine persistent AF model. And they noted increased caspase 1p20 expression in patients with paroxysmal AF. Now, caspase P1p20 I haven't spoken about, but it's an active breakdown product indicating cleavage of activated caspase 1 via the NLRP3 inflammasome. In paroxysmal AF patients, there was no increase in NLRP3 or ASC, so there's no evidence of priming. This indicates activation, which in this and subsequent slides will generally be shown by red, but there's no increase in priming. And patients with persistent AF, they saw an increase in the expression of NLRP3 and ASC, as shown by these darker Western blots for these two proteins, and you can see the increase here in blue indicating increased priming as well as increased production of the breakdown product caspase 1p20, indicating increased activation. And in our canine persistent AF model, they saw evidence again of both increased priming and activation. So now these are expression changes in atrial cardiomyocytes. So there's evidence of increases in cardiomyocyte, NLRP3, inflammasome, priming, and triggering in AF. And what's important here is that this is going on in atrial cardiomyocytes, not in macrophages infiltrating into the atrium. So it indicates that the heart cells, the atrial heart cells themselves, are producing inflammatory signaling. Nali then developed a mouse model with constitutive cardiomyocyte NLRP3 activation to look at the consequences of activating cardiomyocyte NLRP3. So these were mice with a knock-in gene with modified NLRP3 to make it activated constitutively and produce activated signaling of the NLRP3 inflammasome. And you can see that these mice had more premature atrial complexes, indicating spontaneous atrial ectopy. These are examples. You can see the P wave looks different, and these complexes are premature. And the number of spontaneous premature atrial complexes is shown at the right. The knock-in mouse with constitutively activated NLRP3 showed an increase in atrial ectopy, as well with AF induction as an increase in the persistence of AF. So this is AF induction in the control mice. In fact, in a control mouse, and you see there's really no AF induced. In a knock-in mouse, you see this long-standing AF, long-standing for a mouse, induced by premature stimulation. This is the ECG lead and atrial electrogram. And then in a knock-in mouse treated with an organic blocker of NLRP3, and you can see that the atrial ectopy was suppressed. So these are mean data at the right. Actually, this is not mean data, it's the incidence of inducible AF in the mice. So very little inducible AF under control, AF inducible in virtually all mice of the knock-in mice, and the knock-in mice with the NLRP3 blocker showed reversibility. So cardiomyocyte overexpression of activated NLRP3 produces an AF promoting substrate. So in these mice, these are atrial activation maps showing optical atrial activation maps showing the progression of and source of the atrial impulse. So during sinus rhythm, the beat originated in the right atrium. The earliest activation is here and progressed to activate the rest of the atrium, but in the presence of atrial ectopy, the activation came from an ectopic source in a different part of the right atrium and with a different P wave, and the incidence of ectopic activity was enhanced. Dr. Warens and Dr. Lee looked at the underlying cellular basis with confocal mapping of spontaneous calcium releases. And although it's a little difficult to see, you can see that this is two-dimensional map. So the vertical dimension is distance along the horizontal axis in the cardiomyocyte, and the horizontal axis is time in milliseconds. These little bright dots in the knock-in mouse are not present in the control mouse, and you can see these spontaneous calcium releases happening in different places within the atrial cell as a function of time. The spontaneous calcium release frequency and amplitude was enhanced in knock-in mice, and looking at the underlying biochemical basis, we see an increase in expression of ryanodine receptors without an increase in phosphorylation. So this pathophysiology is a little bit like what we see in paroxysmal AF, where there's not hyperphosphorylation of the ryanodine receptor, but there is in fact an increase in receptor expression. So cardiomyocyte NLRP3 overactivation alters calcium handling and causes atrial ectopic activity. These are images of the heart in these mice, and you can see the knock-in mice had larger atria, as documented by the mean data. They also had increased expression of the transcription factor MEF2C and reduced expression of the anti-inflammatory factor RCAN 1.4, increased atrial fibrosis on Masson trichrome stain. These are the examples of the mouse atria with more blue staining indicating fibrosis in the knock-in mice. Increased expression of collagen 1A corresponding to increased production of collagen related to fibrosis, and increased expression of the fibrotic biomarker galactin-3. So cardiomyocyte NLRP3 overactivation causes atrial structural remodeling with prominent atrial fibrosis. And this slide shows the effect of NLRP3 knockdown on atrial arrhythmias in NLRP3 overactivated mice. So I showed you that these mice have chronic overactivation of the NLRP3 system with inducible AF. Doctors Lee and Verens then injected an AAV9 virus containing either a scrambled sequence or a short hairpin NLRP3 knockdown sequence. And you can see that the mice with knockdown of NLRP3 had the elimination of their AF, whereas the scrambled sequence didn't do anything. So NLRP3 knockdown suppresses AF in NLRP3 overactivated mice. What about a model of AF where NLRP3 is not intrinsically overactive? So these are results from a CREM transgenic mouse line that's been studied extensively by Dr. Werenz's group. So CREM stands for cyclic AMP receptor modulator, and this mouse is a transgenic mouse overexpressing CREM, and you can see that these mice actually have evidence of increased NLRP3 activation, which is now not the primary factor, but is secondary to the atrial remodeling caused by the CREM transgenic. So there's increased expression of both pro-caspase-1 and the product. So there's increased, in fact, priming because pro-caspase-1 production is increased, and there's also increased activation with increased expression of caspase-1p20. And these are the mean data supporting that. These CREM mice have a higher incidence of spontaneous AF and have atrial remodeling indicated by a larger left atrial area. Now, then cross the CREM transgenic mice with an NLRP3 knockout mouse, and you can see that that reversed the priming as well as the activation, as well as the triggering of the NLRP3 inflammasome. You can see that it also reversed the occurrence of spontaneous AF and the atrial remodeling indicated by increased left atrial area. So NLRP3 knockdown suppresses AF in CREM transgenic mice that has an unrelated primary molecular mechanism for AF, suggesting that mechanisms that induce NLRP3 activation secondarily induce AF in ways that can be suppressed by targeting NLRP3. So the NLRP3 inflammasome system is activated in patients with paroxysmal and persistent AF, and we see in a mouse model can cause AF. What about other types of clinical AF? So Dr. Dobrev's group studied right atrial appendages harvested from 265 patients undergoing surgery on extracorporeal circulation. What they did was they harvest these atria from a large number of patients, analyzed their biochemistry and electrophysiological properties, and correlated the results with subsequent occurrence of postoperative AF. So looking at atrial cardiomyocytes from patients who subsequently went on to develop AF, as shown by the blue data for post-op AF, compared to control, which doesn't mean these control patients were subjected to any different protocol, but the control patients didn't develop spontaneous AF. And you can see that there's evidence of increased expression, this is at the protein level, of ASC, procaspase 1, and gasdermin D, which I mentioned, the full-length gasdermin D, as well as pro-interleukin-1 beta. So there's extensive priming in these individuals who go on to develop postoperative AF. In addition, looking at the products, so these are now evidence of increased triggering or activation, you see more caspase 1, P37 and P20. These are two breakdown products indicating caspase 1 activation, as well as another breakdown product, caspase 1, P10, gasdermin D, N, and C terminal, indicating the proteolysis of gasdermin D to produce the active conducting gasdermin or diffusible gasdermin D channel that will then allow the cytokines to leave the cell, and interestingly, a statistically significant reduction in interleukin-1 beta in the cells. Now, that puzzled us for a while because we expected interleukin-1 beta to go up in the cell because there was increased pro-interleukin-1 beta. And we concluded that the reduction in interleukin-1 beta was probably due to the increased presence of gasdermin D channels, which were allowing it to diffuse out of the cell, releasing cytokines that then induce local inflammation. So that the intracellular content goes down, but the extracellular content presumably goes up. So atrial cardiomyocytes from postoperative AF patients show increased priming and activation, indicating a role for NLRP3 inflammasome in postoperative AF. Now, how exactly does this work? Well, at least at one level, I want to go to the experiment that I showed you just now. I'll show it to you again in detail, but I want to explain the reasoning that went behind that experiment. So Dr. Dobrev's lab analyzed in detail the cardiomyocytes from patients with subsequent paroxysmal AF and couldn't show any abnormal action potential properties or delayed after depolarizations. So we discussed this in detail and reasoned that there must be something missing at the time of surgery that occurs later on that's involved in producing the AF. And then what Dr. Dobrev's lab went on to do was to mimic the inflammatory substrate in post-op AF by infusing interleukin-1 beta and compare the response of control patients who didn't go on to develop AF and patients who did go on to develop postoperative AF. And they noted that spontaneous calcium releases, which are these things, so this is F over F divided by the back, so this is fluorescence divided by background fluorescence on confocal microscopy of atrial cardiomyocytes from patients who did not go on to post-op AF in response to infusion of interleukin-1 beta, and they did have some spontaneous calcium releases, but these were very few. You can see this is a 10-second time frame, and this is the number of spontaneous calcium releases over probably about 30 seconds here. In contrast, you can see that the post-op AF patients had many more spontaneous calcium releases in response to interleukin-1 beta. And this bottom slide at the left shows the susceptibility of cells to spontaneous calcium events, which was greatly enhanced in postoperative AF cells, postoperative AF patient cells. And you can see the incidence of spontaneous calcium events was much greater in the cells from postoperative AF patients. So that led to the concept that cardiomyocyte NLP3 inflammasome, possibly also with a contribution of NLRP3 inflammasomes in other cell types like leukocytes, adipose cells, or fibroblasts, acts via CAM kinase phosphorylation of the ryanodine receptor to produce a potential AF substrate. But this substrate on its own is not enough to produce AF unless it's acted on by regulatory factors and triggers, which then can produce paroxysmal, post-op, or persistent AF. Okay, so I just want to point out that this then provides a unifying concept that post-op AF and perhaps other forms of secondary AF, like that associated with infection or sepsis, may involve a chronic substrate and an acute inflammatory trigger, which would explain why patients with secondary AF are prone to develop spontaneous AF subsequently, because they have the same cellular substrate as AF patients, but perhaps it just hasn't reached the same level, the level required for spontaneous AF in the absence of a superimposed factor. So the question we raise is whether anything can be done to suppress atrial inflammatory signaling safely, given the critical role of inflammation in wound healing. You don't want to have a global anti-inflammation intervention that would suppress natural wound healing that's critical for biology. So that led us to examine the system of inflammation resolution, which has been studied over the past 10 to 15 years, whereby inflammation not only causes the production of products like prostaglandins and leukotrienes that are inflammatory stimuli, not only causes the production of prostaglandins and leukotrienes that induce inflammation, but also activates the production of other products such as lipoxins, aspirin-triggered lipoxins, ATLs, and resolvins, which derive from eicosapentaenoic acid and docosahexaenoic acid, which are well known to be omega-3 polyunsaturated fatty acids. So the idea here is that these products of EPA and DHA promote active resolution of inflammation. And so not only do you have inflammation in response to a stimulus, but you then have products that result in active resolution of inflammation, whereby these pro-resolving anti-inflammatory products produce sequestration of pro-inflammatory cytokines, promote leukocyte clearance from epithelial surfaces, phagocytosis of apoptotic neutrophils, promote removal of inflammatory debris, and reduce pain. So we decided to test one of these derivatives, resolvin D1, in a right heart disease model of AF. So in this model, we produced pulmonary artery hypertension by the injection of monocrotaline, which is a toxin that causes pulmonary hypertension. So This is a rat model. You inject monocrotaline at day 0 and then study the rats at day 21. Systemic pressure and left ventricular systolic pressure is reduced concomitantly with an increase in right ventricular systolic pressure due to pulmonary hypertension. These rats have inducible AF during in situ transesophageal stimulation-induced EP study. These are overall data showing a great increase in the inducibility of AF and in AF duration in the monocrotaline rats. They also have slowing in atrial conduction shown by optical mapping, reduction in atrial conduction velocity, as well as prolongation of atrial APD. So monocrotaline rats have slowed RA conduction and increased action potential duration and refractory period. They also show structural remodeling in terms of increased fibrosis. So these are right atria from monocrotaline rats showing, this is a control rat, a monocrotaline rat showing increased fibrosis. And these are the mean data showing a substantial increase in right atrial fibrous tissue, the right atrium being more affected, of course, in pulmonary hypertension because of the right heart disease, some dilation of the right atrium. The left atrium is also affected, presumably by neurohormonal signaling, with not as much fibrosis, but nevertheless an increase in fibrous tissue and no dilation of the left atrium. So monocrotaline causes marked right atrial fibrosis and RV dilation, moderate LA fibrosis, but no dilation. And we see that there's evidence of inflammasome activation in monocrotaline exposed atria, an increase in the right atrium in NLRP3, caspase 1 and caspase 8, and a tendency to increase in interleukin 1 beta. So inflammatory signaling gene expression is enhanced in monocrotaline atria. It's also enhanced in the left atrium in rats subjected to myocardial infarction. And then we asked, what would happen if you gave Resolvin D1 to enhance inflammation resolution in this model? So we see not much change in pulmonary artery wall thickness, a slight reduction. So any benefit is not due to a reduction in pulmonary artery toxicity produced by monocrotaline, no change in right ventricular hypertrophy measured by right ventricular mass divided by left ventricular postseptal mass. So Resolvin D1 slightly reduces the pulmonary artery arterial response and has no effect on right ventricular hypertrophy, so no direct on the right heart disease, but you see a substantial reduction in AF inducibility in vivo. This is AF percentage of rats with inducible AF and atrial flutter. 100% of them were inducible after monocrotaline therapy. In the absence of Resolvin treatment, Resolvin 1D substantially reduced the fibrosis, reduced the induced AF. It also substantially reduced the fibrosis in the right atrium shown here and didn't affect right atrial dimensions. Left atrial fibrosis was also reduced by monocrotaline D with no change overall in LA dimensions. And in optical mapping, monocrotaline substantially slowed conduction velocity, and this was largely reversed when the rats were pre-treated with and concomitantly treated with Resolvin D1. So Resolvin D1 attenuates in vivo AF vulnerability, conduction slowing, and atrial fibrotic remodeling in monocrotaline rats. Looking at the molecular changes, gene microarray data, these are the 10 genes with the largest fold change. You can see that 4 of these 10 genes are genes reflecting cytokines and inflammatory products like interleukin 6 and CCL2, CXCL1 and 2. Monocrotaline, so now we're comparing monocrotaline plus RVD1 versus monocrotaline alone. looking at how RVD1, resolvin D1 suppress the responses to monocrotaline. You can see a dramatic reduction in the expression of interleukin-6 and CCL2, as well as CXCL1 and CXCL2. These are all right atrial data. And the left atrium, you see similar kinds of changes, but fewer genes involved and quantitatively smaller changes. So resolvin D1 strongly attenuates changes in atrial inflammatory cytokine, chemokine genes induced by right heart disease. So in summary, atrial cardiomyocyte inflammatory signaling involving NLRP3 and activation appears to be a common signaling mechanism implicated in various clinical forms of AF, including paroxysmal, persistent, and postoperative. Downstream pathways include calcium mishandling, structural remodeling, and possible ion channel expression changes. And finally, molecules that promote the resolution of inflammation may be useful in preventing pro-inflammatory remodeling. Thank you very much for your attendance, and now I'll be happy to take any questions.
Thank you very much, Stanley, for this wonderful talk. Is there any question in the audience? Yes.
Thank you for your presentation. It was very interesting. My question is about depression. In the many lecture I see there is not definition of the mechanism of depression. I mean, I know that serotonin is implicated in too much in sleep. Is it the same mechanism like sleep apnea, or it's another mechanism? I see in my short experience, I see a few patients who develop depression after who develop atrial fibrillation after depression without any other etiology, I mean.
So that's a very interesting question. The question is, how does psychological factors affect the atrial substrate? And the short answer is we don't know. Of course, there are some animal models of depression. How good they are, I don't know. It's really not my area, but certainly an interesting area to pursue. But we don't know. I also haven't seen clinical data clearly demonstrating a link, but there is a very clear link between psychological distress, depression, psychosis even, and various forms of heart disease. So at the very least, atrial structure and function and AF likelihood will be affected secondarily from the heart disease component. But what the direct effects on the atria of psychological and psychiatric factors are, I don't think is known.
Okay, thank you.
Other questions? No, I have a few little, maybe simple questions and maybe general questions. In the first part of your talk, you told us about the different kind of substrates for atrial fibrillation with your conceptual figure, making reference to AF-induced remodeling, cardiovascular disease-induced remodeling, and aging-related remodeling. Are all these remodeling, could you explain what are the common points between these three kinds of remodeling, the differences between these three kinds of remodelings, how they differ from each other, and how do they interact with each other? Because aging remodeling, it's difficult to act on it. Cardiovascular remodeling, it is possible. AF-induced remodeling can be targeted by prevention AF. So are there common points and important differences between these three kinds of remodeling?
Sure. Okay. So I really didn't talk about aging. That's an area that we're studying in detail. One common point, I think, in all of them is tissue fibrosis, which we don't really know the pathophysiology of, but inflammatory signaling probably plays a role in all of them. In aging-related fibrosis, we've been looking at that in some detail, and it seems that cellular senescence plays a role, and that senolytic drugs may actually be able to have some value in prevention. Or whether those kinds of agents are selective enough and safe enough to use to prevent aging-related heart disease is a question that probably will come up and be investigated extensively in the next 10 to 15 years. So the common feature, inflammation is certainly a common feature to many of these factors, certainly to AF-related and heart disease related and likely to aging related, low-grade cardiomyocyte mediated inflammation, and possibly inflammatory signaling through other cell types like fibroblasts, adipocytes, etc. The points of difference, AF-related remodeling includes a major component of electrophysiological functional changes that are not common, not seen with the other conditions. So action potential shortening and spontaneous calcium releases are common in as a consequence of AF. With cardiovascular disease, it's less clear. I wouldn't be surprised if DADs occur, but action potential shortening does not occur. And I think with aging as well, DADs may occur. There is some evidence for them, but action potential shortening probably doesn't. So the common feature, I would say, is inflammatory signaling and fibrosis. And the distinct feature, at least of AF-related, is action potential abbreviation due to downregulation of calcium channels and upregulation of potassium channels.
Well, I have another question related to your global view on what should be done to treat, and I would rather say prevent AF. You said that you were more confident on the fact of targeting the risk factor by itself rather than focusing on a particular pathway activated by this risk factor. Anyway, there are some risk factor, and obesity is with no doubt one of them, which are very difficult to control. There's a lot of patients who are refractory to weight loss and any kind of strategy to help them to weight loss. So in this case, it should be useful to have a way to targeting a mechanistic pathway, because you can address the risk factor by itself. So in the case of obesity, could you tell us about what kind of mechanism, maybe hormonal mechanism, were triggered by obesity to end up with atrial fibrillation, and, as I understand by what you said previously, maybe atrial inflammation?
Okay, so the question is very good. It's also very complicated. I would point out that one major factor through which obesity promotes AF is the hemodynamic remodeling that occurs. The heart gets larger, the atria get larger, that the lean body mass increases because it requires more muscle and more heart muscle to support the much larger body mass. And that's definitely a major factor involved in AF induced by obesity, which is not going to be addressed by addressing inflammation or fibrosis. As far as the kinds of inflammation and fibrosis that are promoted by obesity and other aspects of structural remodeling, I guess it may conceivably be possible to attack that by intervention, but the intervention is not straightforward. So if you can get the risk factor suppressed, then clearly that is going to or can occur with targeting of the underlying mechanism without real toxicity, unless you're forced to use drugs that act on the CNS or something like that. But for example, if you use a combination of decreased food intake, more exercise, possibly SGLT2 inhibitors to attack obesity, then you can effectively cause weight loss without a lot of other side effects. When you get into trying to prevent things like inflammation and fibrosis, it's potentially a much dicier area because these are aspects that are involved in homeostasis. So you need targets that are very safe and are only going to suppress pathological long-standing inflammation rather than acute inflammation required for healing or suppression of infection or things like that. It's not impossible to do that, and the Resolvin work suggests that it may be able to be done with limited toxicity, but for sure, the challenges in developing a therapy that targets the end product or the downstream signaling is going to be much more challenging than if you can suppress the primary process. I definitely agree with you that in some cases, people will not be able to or sufficiently motivated to suppress the primary risk factor themselves, and then you have no choice. So you're stuck treating intermediate factors or the atrial substrate, and it's worth trying to do. It's definitely worth trying to do, and it's important, but it's definitely much more challenging. As far as a more direct answer to your question, which I think you would have liked to know, like which adipokines might be involved, is it a direct result of fat, or is it different for different kinds of fat, white fat, brown fat, tissue fat, atrial fat, pericardial, epicardial? Those answers there are some answers to those questions, but they're not definitive.
To finish, I have two quick questions I will ask at the same time. You made the difference between electrical remodeling and structural remodeling related to fibrosis. One likely to be reversible, the other one is not. One is more AF induced, the others are more induced by the background, the aging, cardiovascular disease, and so on. Do you have any clue about by which mechanism this electrical remodeling is induced? Do you think that a kind of ischemic phenotype of atrial fibrillating cardiomyocytes can be a trigger of this electrical remodeling, which is rather adaptive in some way?
Yeah. So the signals for electrical remodeling appear to involve calcineurin and possibly phosphorylated kinase 2. The extent to which ischemia per se is involved, I really don't know, but certainly mitochondrial remodeling appears to be very important. And we have some data in the sheep model, as well as very extensive data in the dog model, suggesting that changes in mitochondrial function and mitochondrial damage from chronic reactive oxygen species, which are produced to a greater extent in AF, may be very important. And we have some data with a mitochondrial respiration promoting intervention suggesting that it may be amenable to therapeutic intervention. But that's a very extensive subject outside the purview of what we can deal with today.
One last quick question. Do you know why atrial epicardium is more susceptible to fibrosis than atrial endocardium?
It's a good question. Nobody knows. It could be that there's more fat on the epicardial surface and that it's the toxic effects of fat of adipose tissue that are important. There might be other factors like hemodynamic factors, local stress and wall tension, greater local ischemia, greater local metabolic demands and metabolic remodeling. But that would require extensive and detailed studies of atrial epicardium versus endocardium, of which very little has been done.
Thank you very much, Stanley. I look around to see if there's any other questions. Obviously, the answer is no. Thank you very much, Stanley, again for being with us this afternoon. Hope to see you soon in good conditions for you, and hope everything will go okay.
Thank you very much. And I would love to be on site in Bordeaux. I was really looking forward to it. And I think it was much easier for my hosts to accept the fact that I had to cancel than it was for me to cancel. It was really a struggle, but in the end, there was no choice. But anyway, thank you very much. And I hope
Thank you. Thank you to you. See you soon. Bye, Stanley. And I mail you. Bye.
Bye-bye.